Now we'll go on to our next speaker. It's my pleasure to introduce Dr. Supriya SRIGANESH, who is a senior consultant cataract and refractive surgery at Nethadama Super Speciality Eye Hospital, and she's also the executive director of Nethadama Hospitals Private Limited. And she's going to talk to us today on managing post-op refractive surprises. So you have done everything for it to go right, but when it goes wrong and when you have a dissatisfied patient, how do you manage them? This is very important. It's not only how you get into Chakravyuha, but also how to get out.
Thank you so much for that kind introduction. It's always a pleasure to be here at this IC, and I have an interesting topic today, managing post-operative refractive surprises. So when you have a patient who selected a trifocal lens, an expensive package, and then they develop a post-operative refractive surprise, how do you deal with them and how do you figure out what to do next? So the first thing you need to do is go back, right? Go back and check your biometry, recheck whether you've used the correct IOL formulae. Have you used something to correct their cylindrical power like a toric lens or LRIs? Have you operated on the right patient and the right eye? And has any of your staff done a human error while entering the data into your system? So the moment you know what has gone wrong, then that calms you down, and then you can figure out what to do about it. So when you have a minus residual refractive error, always check whether you've done the adjustment for a sulcus IOL. It can also happen in bag distension syndrome and or capsular contraction syndrome. So make sure you dilate the patient and look for these things. If you have a plus residual refractive error, check whether this patient has undergone refractive surgery in the past, has not told you about it, and you've missed possibly a PRK done in the past or something like that. And plus residual refractive errors can also be seen with plate haptic lenses. Okay, so we already went into this, so I'll not cover it again. So now that you have the residual refractive error, what are your options? Now you have non-surgical options. If your patient doesn't want to go in for a secondary surgery, you can always prescribe them spectacles and contact lenses. If they are more comfortable with that, better not to touch the eye. What are the surgical options? Now you have cornea-based procedures and you have lens-based procedures. Once the lens is in, if it is a monofocal lens, you can do cornea-based procedures, PRK, LASIK, SMILE. The other option is to do lens-based procedures. If it's just a rotation of a toric IOL, you go back in and rotate it back into the correct position. You also have the options of implanting a second piggyback IOL into the sulcus. You have an option of implanting a piggyback ICL. You can just take out the IOL and exchange it with the correct lens, or you can also do an optic capture, which is an interesting option which we'll be seeing. Okay. So when do you opt for these? How do you make these decisions? So cornea-based procedures you opt for when it's a low refractive error. So if you have an error less than -2 diopters, there's no other corneal pathology in the eye, no significant dry eye, because these patients are older. You have to be a little careful about doing LASIK in these patients because their dry eye can worsen. You need to make sure that there is no other photic phenomenon, dysphotopsia happening in the eye, then you can select. How long do you wait? You need to wait for at least 3 months after the initial surgery and make sure that the manifest refraction is completely stable before going ahead with a cornea-based procedure. Now the eye trace is a very interesting and helpful tool for us in toric IOL rotation, and the rotation ideally must be done within 2 weeks. So we usually call the patient back after 1 week, dilate them for an axis check and make sure that the lens is on axis. In case there's any rotation, we also get an eye trace done. Now this module in eye trace tells you exactly how much rotation will give you how much change in cylindrical power, and accordingly you can rotate the lens back into position. Now coming to the IOL piggyback options, this is how do you calculate the power of the lens, right? For the piggyback lens, this is an axial length independent calculation. So you have to do a very careful manifest refraction calculation. And for hyperopic errors up to 7 diopters, the spherical equivalent is multiplied by 1.5, And for hyperopic errors beyond 7 diopters, the holiday R formula or refractive divergence formula can be used. So this is an overview of how you do the piggyback IOL calculations for an underpowered pseudo-fake. That is, if you have a hyperopic residual refractive error, depending on the length of the eye, you do, for short eyes, you multiply it by 1.5 and add +1. For an average eye, it's 1.4. For a long eye, it's 1.3. Similarly, for myopic residual refractive errors, you -1. So for a short eye, you do 1.5 into the spherical equivalent, average eye 1.4, long eye 1.3, but you -1. So this is just an overview of how to calculate the sulcus. Now, which lens to use as a piggyback? You have multiple options. We use the Rayner Sulcoflex. You can also use 3-piece silicone IOLs which are available, and you can also use an ICL as a piggyback lens. So this is a little bit about the Sulcoflex. It has a hydrophilic acrylic IOL, and basically it has a round edge and it has a concave posterior surface with a convex anterior surface so that it can fit nicely into the sulcus. But there are complications of polypseudophakia. If you do a piggyback lens, you can have pigment dispersion, pigment between the IOLs, iris transillumination effects because the IOL is rubbing on the iris. You can also have uveitis, glaucoma, and something called interlenticular opacification, and also a hyperopic shift. So you need to keep in mind and counsel your patients that these are a possible complications of piggyback IOLs. So now let's look at some interesting videos. This is a case of a patient who was actually post-RK, and this patient had a residual refractive error. So this is Dr. Ganesh's video where you can see this dense PCO. The posterior capsular opacification was removed by going under the lens and doing a posterior capsulotomy, after which the Sulcoflex piggyback IOL was used. So here the lens is neatly implanted into the sulcus, and this patient was actually a post-RK patient in both eyes. So what was planned was a mini monovision in both the eyes with the Rayner Sulcoflex lens, and in this eye the posterior capsulotomy was also done. So you see here at the end of the surgery, it's post-RK, the central opacity is cleared and the piggyback lens is in place. So although this is a complex procedure, you see both the lenses in place there on the AIOS2025, and you see here after doing this for both the eyes, this was what the refraction was. The right eye was seeing better for near, the left eye was seeing better for distance, and binocularly this patient was very happy. So imagine in a post-RK eye doing a piggyback lens and achieving mini monovision with 6/6 outcome is very interesting and an excellent outcome. So now coming to IOL exchange, in a lot of scenarios you need to be able to exchange the lens if you have a residual refraction. This was one such case where the patient had a trifocal lens which was implanted. I'm not able to play the video. Can you help me? I'm not able to. Go back, please. Yeah, thank you. So this is a trifocal lens which is in place, and this is a technique for IOL explantation. So you need a particular toolkit of instruments. You can see here there's not much opacification, so you can put visco into the bag, lift up the lens, hold the lens with the lens holding forceps, and the lens cutting forceps is used to cut it 3/4 of the way. So you don't need to cut it all the way 3/4 of the way, but the incision needs to be extended a little bit in the shape of a trapezoid. So you hold one edge and rotate the lens out using the trapezoid incision. It comes out very easily with very little manipulation, and the correct powered IOL can be implanted. So this is one of the techniques for IOL exchange. Okay. Now this is another case where we see, sorry, can you play the video once again? Can you go back, please? Yeah. Yeah. Sorry. You're not able to play it? I had checked, it was playing.
The video is not playing.
I just checked, it was playing. All right. So I think this video just highlights the importance of when there are adhesions, a fine iris repositor can actually be used to remove those adhesions. I think in the next video also we can see that. See, look, this is a plate haptic lens. So fine iris repositor again is used to actually dissect these adhesions. This can be very valuable step, and a dialer is just used to pick up the lens out of the bag. Now we have to be very careful when these adhesions are there because you can cause a ZD. So again, a fine iris repositor is used to completely separate the lens from the bag. Now these can be very tricky situations. Here most of the lens is removed from the bag. In plate haptic lenses, we cut through the middle of the lens, the entire lens, and remove it piece by piece. Now while removing the left piece, you see here that adhesion is not removed, so it's pulled. So there's a ZD that happens there, and this is a Nightingale polisher which also can be used to polish off the PCO. So this is an excellent tool which can use, it's a blunt, non-traumatic polisher. And here the bag is again inflated with viscoelastic, and a CTR is used to stabilize the bag. Now once you know that the bag is completely stable, it is safe to implant a trifocal lens in the right axis and the lens of the right power to make sure that the IOL stability is achieved. So here you can see the bag is stable and the lens is implanted. Okay, so this was actually a patient who was very uncomfortable with the trifocal lens. So a monofocal lens has been implanted after the IOL exchange. So I'm ending with one last case, which is an interesting case scenario. This was a 54-year-old female ophthalmologist who came in for an opinion for refractive correction. She wanted to get rid of her glasses. This was what her refraction looked like. Clear lenses, normal retinal examination, but this was the topography. So she was not actually suitable for a corneal refractive procedure because of a borderline cornea. Now anterior chamber depth was also very less. It was 2.32 and 2.27 in both eyes, so she was also unsuitable for a toric ICL. So the surgical plan was femto laser assisted refractive lens exchange with the implantation of a trifocal IOL and arcuate incisions. The calculated IOL power was plus 15.5 diopters and 11 diopters, and this was what was planned. Now, the surgery was completely uneventful, but 3 weeks post-operatively, she had blurred vision, and you can see with a trifocal lens, she was only seeing 6:12 and 6:9 for distance vision. So she was quite unhappy after the procedure, but with correction, she was improving to 6/6. So this is clearly a residual refractive error. Trifocal lenses are in, and this is an ophthalmologist, right? So it's a tricky situation. What do you do? So this was again the AIOS2025. So you can see here the anterior hyaloid phase and the structure of the IOL and the posterior capsule that's there. So a very interesting way of management was done. We'll have a look at that here. So the incision was carefully opened up. The same incision was opened up. All right, and here you can see that after injecting viscoelastic and carefully dissecting the edges of the capsulotomy which were fused to the IOL, make sure all the adhesions are carefully dissected and removed. A little bit of visco is also injected under the capsulotomy into the bag. Now, this was Dr. Ganesh's case, and he's injecting visco into the bag because he's planning something very tricky. Here, a side port is made, and look at this. This is a cystotome. He's actually going under the IOL and performing a posterior capsulotomy. So why is he performing a posterior capsulotomy in an eye with a trifocal lens? Because he's planning a posterior IOL capture. So here you can see that the residual refraction was about 1 diopter. So you just need a change in position of IOL to cause that change in 1 diopter. So very carefully, a posterior capsulotomy is done using a forceps. Here, it is a tricky situation, and it needs to be very carefully managed. One of the ways is visco is injected into the primary opening so that you create space there to do your capsulotomy. And a good posterior capsulotomy is achieved. After that posterior capsulotomy is done, the IOL is actually captured into the capsulotomy. Now, it's a very meticulous movement because you cannot afford to have a vitreous loss here. Carefully, the trifocal lenses were captured into the posterior capsulotomy, and a meticulous removal of viscoelastic was done. So after this, you can see how the refraction changed. So exactly what we were looking for, and the spherical is 0, patient is seeing 6.6 for distance. And this was the clinical picture, perfectly stable IOL and the good refractive result. So the take-home message is, of course, prevention is key for a post-op refractive error, but you also need to communicate with your patient, speak to them about what has happened and what are their options. You need to have an algorithm in your mind to manage the refractive error, and like you saw in the last case, even very unconventional options can work well. So you need to think out of the box and also be a very skilled surgeon for the last case. But these are the options and how to manage the residual refractive errors. Thank you so much for your patient listening.
Thank you very much. And as we come to the end of the session, if there are any questions from the delegates, please. Mike, please.
I'm just missing your name, Dr. Sushmita. Yeah. In one of your presentation, you had said that it's a post-RKI where a femto-assisted laser cataract surgery, just to calculate that IL power calculation. My question is not actually pertaining to that IL power calculation, but in a case of RK operated case, and if you are planning a femto-assisted, what all precautions you should take, and what are the minimum cuts that you expect to proceed with the femto-assisted laser cataract surgery?
Basically, when you are doing a femto-assisted cataract surgery in a post-RK, you will have to look at the scarring which is there and epithelial plugs. If you have thick epithelial plugs and scarring, this can block the laser and you can have tissue bridges. So it's very important that you don't do flax in cases where there is scarring post-RK. That is one issue. The second is if there are multiple incisions. Sometimes you have 32 incision RKs. In these cases, if you do a clear cornea, then the RK incisions open up, and then you can, it's very difficult to manage, it's very difficult to suture. So all these cases you have to do a scleral tunnel. If your RK incisions is a 4 incision or 8 incision RK and there's adequate space between the incisions to make a 2.2 incision, then you can do a clear cornea and then manage. Docking is not an issue. Docking is not an issue. You get a good capsulotomy also. So routinely I've done quite a few cases. Only thing is you may not get a completely free floating capsulotomy. So I always kind of go in, use the forceps, and then do in a rexus-like motion. So if there are any small tags, then you don't have a runoff. Yes.
Sir, I have a question. Sir, in the last case which Dr. Supriya presented, not that as a beginner surgeon some ophthalmologist will come to me for a cataract surgery, but just if I have other normal patients, sir, and if I encounter a similar situation, so what would you advise? Because I'm not that comfortable with the PCC right now.
See, the options were, one is to do a refractive surgery correction, but the problem is 54-year-old female, she had some amount of dry eye and her corneas also were abnormal. So you can do a PRK. So in older patients, the chance of it going in for ectasia is more, but she didn't want a cornea procedure. Okay. She said, no, I don't want a cornea procedure. The other option was an IOL exchange. Now we again recalculated with biometry, and it was turning up to be the same lens power. So I don't know whether there is a manufacturing mislabel, because the other eye was okay, whether there's a manufacturing mislabel. If so, then yes, if I exchange the lens for the same power, it'll be okay. But again, it's a tricky situation. So it's not showing you a different lens to exchange. And so you can't do a lens exchange. Then for piggyback lens, I told her the option is, okay, you can put an ICL or a piggyback, but she didn't want 2 lenses in the eye. She said, no, I don't want that. So then I was just racking my head as to what I can do, and she was unhappy. And these patients with trifocal, if you have a myopic residue, then their night dysphotopsia increases. And they're miserable. So it's okay to have slightly plus 0.25 rather than to have minus 0.5 or 1 diopter. And then I was thinking, what can I do? Then I thought, okay, what if we can shift the ELP? If you shift the ELP posteriorly, you get a hyperopic shift that will correct the myopia there.
Yes.
And that's how I kind of said, okay, I'll plan this. I discussed with her. I said, okay, I do pediatric cataracts. I'm quite comfortable doing a PCCC. So I said, we can try this and do it. And she said, okay. And then, so that's why I have this interesting case.
So, but if the biometry had some changes, in that case, the lens exchange would be a
Yes.
better.
You can do a lens exchange. If the biometry showed you a totally different power, then maybe there was some problem in the biometry, maybe dry eye when you did the biometry, or because of an optical biometry. Usually the difference is because of dry eye, because with the IOL master you see the foveal pit, the axial length measurements are very clear, so it's usually the K readings. And in myopic patients, again, because of the ELP calculation problems, you can have a little bit of surprise. If there was a big difference, then you could do an IOL exchange. But this was a small, like 0.75 or so, so shifting the ELP kind of helped.
Thank you, sir.
Thank you very much for all the interesting talks. Just one quick question. When you are implanting a sulcus piggyback lens, does it matter what material the original lens implant is, whether it's the old silicone type lens or whether it's a hydrophobic lens or hydrophilic lenses? Do you have to match materials?
You don't have to match material. It's better not to use the same material. The guideline is don't put two lenses in the bag. So if there's a lens in the bag, then you put the lens in the sulcus for a piggyback, if you're using a piggyback. So you can put a 3-piece lens in the sulcus, and suppose there's a silicone lens in the bag, then you use a hydrophobic lens in the sulcus. So if the material is different, then the chance of the interlenticular opacification is less. So that's the kind of guideline.
So you want to deliberately mismatch?
Yes,
the material.
deliberately a different material.
Thank you.
I operated one case with a hypermetroph, axial length around 19.9. Barrett and Haggis, all formulas were showing result around 34 IOL power. I implanted the same EDOF lens, but my surprise, I did the patient both eyes simultaneously. Both eyes were having the similar size, and I got the surprise of -4. So what is the reason? Means why I should what I miscalculated? Yes, I operated one eye again with the Sulcoflex from Care Group, and it was 6.6, and other eye I kept -3 only. So patient is happy, but I don't know what went
See,
wrong.
there are many things that can go wrong. One is the formula. I usually like to look at for high hyperopes, I like to look at the Hoffer Q. The Hoffer Q is actually kind of in small axial lengths, the Hoffer Q may be little more reliable, but the Barrett also gives good results. The problem is also in the effective lens position, because even a small shift in effective lens position for a high powered lens will give you a big refractive surprise. And sometimes the design of the haptics can make a difference, because if the design of the haptics is not okay, or if you have long haptics, most of these high hyperopes have small bags. So sometimes you can have like an anterior shift of the lens, and then that changes the ELP, and you can get a myopic surprise.
Checked AIOS2025 also. Lens was in the bag and towards
Anterior.
the posterior surface only.
Okay.
But and Hooper Q was also showing same 33 only. Still -3 error.
So it is notorious. The short axial lengths are notorious for refractive surprises. The non-ophthalmic eyes, so you have to be quite careful. But if you have some amount of myopic surprise, if the cornea is normal, you can always do a corneal refractive surgery.
Patient
Because
was
even if you
30 year only, so
yeah, even if you exchange the lens, you can still have a surprise, because you never know the ELP and where the lens is going to sit.
therefore I didn't opt for IOL exchange.
Yeah. So you can do a Sulcoflex, or you can.
Yes, I go for.
Yeah.
Thank you.
Thank you. None of them, yeah. Too short, yes. But you'll get a hyperopic shift. You'll get if the ELP is deeper, you get. Okay. It is a difficult situation. Yes, I think we'll take the last question and wind up because we are.
Thank you for such a nice presentation. I have a question for Toric IOL. Suppose we did a perfect pre-op
Alignment.
evaluation, everything done perfectly, and we get surprises of plus 1.5 diopter of astigmatism. What will be the chances of error in?
See, basically you look at the.
Suppose the patient is come late after 3-4 weeks. Can we do rotation or repositioning of the IOL?
See, one of the commonest reason why you get a surprise is if you have dry eye pre-op. If you do your biometry and then the patient has dry eye, you can have the K readings off by almost like 1.5 diopters, and post-op you'll get a reflex. So you have to see that the ocular surface is pristine when you're doing your biometry. That is one aspect. The second is when you have a rotation, generally you have mixed astigmatism. You have plus and minus. You'll have like +1, -2. So you know that, okay, if you rotate the lens, you're going to go to plano. You have a online formula, astigmatismfix.com, or you can use the Barrett RX formula, or you can use the iTrace, and that will actually give you the amount of rotation and what will be the residue. If you go to astigmaticfix.com, you have that. You can put in the model of the lens, and then what is the post-op residual refraction. It will tell you how much to rotate, whether rotation will help, and after rotation what will be the residue. And you can rotate. Generally I prefer to rotate after a week or 2, because then the bag is a little sticky and then the lens does not rotate so much. So if you rotate immediate post-op, there's a chance of re-rotation. So you wait for like 1 or 2 weeks, the bag is a little sticky, it has collapsed, then if you rotate, then the chance of re-rotation is less.
But the question is why patient came late?
You can open up the bag. Even at 1 month you can kind of open up the bag. You do a visco dissection and fill in viscoelastic, and you can rotate it.